Question from Professor Youssef.
So my question, not a question, it's a comment to the first speaker. You did mention in one slide the intraoperative difficulty with the MRI. We did 2 studies on that using the ADC map. One was point of interest.
Edema of
The ADC map on MRI. And we had a point value of the tumor. So we proved the middle value within certain range was associated with worse outcomes, which is a reflection of intraoperative difficulty. Then we did repeat again that study on a larger scale with the entire tumor histogram, and we got the ADC value for the entire tumor. We did prove again that the middle value was associated with worse outcomes in terms of facial nerve and hearing. We did not establish direct correlation with adherence or tumor consistency, but we used the outcome as an indirect indicator. So I think the ADC map, there is some future there that if we do the ADC map, the histogram for the entire tumor in every patient, the large tumors in particular, we can get somewhere with that.
Thank you. We have a question here. Can you introduce yourself as well?
I saw the surgery, a very nice presentation. I just have a couple of comments. Number one, when we over a period of time, I have about 2,500 CP angle tumors. We do not do the lateral cuts on the dura. And that had changed my leak risk, number one. So it's a single semilinear incision, number one, which helps in primary dural closure. Reinforcing the dural closure with fat has significantly reduced again. So every single patient of mine, even if I have a complete closure, I reinforce with a layer of fat and suture it over that. And a very nice presentation, Professor Broggi. You were a legend, you have very large experience, but I'm surprised that your last conclusion, you said image guidance. I have never used it. I don't know how many image guidance you have used for CP angle tumor. I'm surprised with that conclusion. Thank you.
If I make a comment, young generation are using image guide for everything. And I think that, at least in my country, that is something that is overused.
If I may speak on that, especially in training, I think that I don't utilize the image guidance, but I have it available for my residents so that when they are doing the approach, they understand. It improves the safety, but it also enables them to do a little bit more and to gain confidence and understand the anatomy better. But we don't use it during the actual surgery. Of course, I don't think the surgeons need them during the surgery, but I think it's a good training tool, it facilitates training.
Yes.
Question?
Yes, I have a comment regarding the guidelines, the presentation guidelines that was very comprehensive. So I really appreciate that. But I'd just like to go a step back. Guidelines are what they are, guidelines. When you look at the level of evidence presented to support the guidelines, mainly they are level 2 or sometimes level 3. So really, although the guidelines, they are there, we should not be slaves to the guidelines. Guidelines are guidelines. They need to be interpreted. And when you dig deep into how the recommendation come, you find a lot of papers that are level 2 or level 3, support level 2 or level 3 evidence. So guidelines are good in general, but they need to be interpreted, and we need to pay attention to the papers that are used to create the guidelines. Second thing is that retraction is not a swear word. So you need to use retraction and retraction whenever you think that they are useful. When you don't put a fixed retractor, you also do retraction by using the instrument. And sometimes putting the instrument in and out may, in and out of itself, create problems that then at the end, you end up, when you finish the operation, with an indentation on the structures that is no different than when you use, sort of conventional retractor. So retractor is not a swear word. Thank you.
You want to?
Yeah, let me make a comment on this issue, because I think when we end up, trying to do clinical trials or trying to do surgical procedures like the MASSIN studies, we made surgeons kind of go through a process of learning and seeing what their complications rates were. And then we use the data from those kinds of studies to make decisions. But when you look at these, as you alluded to, low-level retrospective studies, you're going to get a lot of variability. And there are not people who are doing this for a living. They don't do enough of the, let's say, vestibular schwannomas and so forth. They're going to get a wide variety of results. I think that's where we run into problems. And then what happens is we then legitimize people who will actually do surgery, say at 3 o'clock I stop, and then I do radiosurgery another time. This is what happens when you have guidelines that really don't show that the effort to take out a tumor and to preserve function is really made.
I think some of that difficulty comes when surgeons are doing both the surgery and the gamma knife. But, I had the fortunate training under Dr. Steiner at University of Virginia, and then Jason Sheehan. They do the radiosurgery, I do the surgery. And it becomes very committed. There's really no other alternative if you are committed to the surgery. But I find with those two that they refer patients in many situations for surgery. It's really, when we have expert level radiosurgery, the indications become smaller. But when we have, laxity in the use of radiosurgery, it's a problem. Professor Momjan.
Robert Jean from Montreal. For Professor Singh, I don't think all schwannomas should be treated. About 40% of schwannomas don't grow. Another 40% grow slowly, 1 to 3 millimeters a year, and about 20% grow fast. So you don't need to treat it by radiosurgery or any means, except following up. We in Canada have the luxury to follow up because it's a social system, and we can produce statistics of the life expectancy and the nature of schwannomas. I have schwannomas that haven't moved for 30 years. The presence of the schwannoma, I think the best way to go around, because of course, when you read the literature, you go nuts. Should I do radiosurgery? Should I not treat? Should I follow? Is to have a tumor board. This is the key. I'm not a very democratic person in my thinking, but I believe in tumor boards because you get the experience of many surgeons and the experience of the radiation oncologist, and you get a concerted, well-thought idea about what to treat a schwannoma.
Dr. Ali, did you have a question? Oh. We have just a couple more minutes before we need to stop.
My question is addressed to Dr. Mishra. You mentioned about the patient with shunt. How often use the patient with the heart defilements and huge, and how you evaluate it? How much is helpful for you during your surgery when you remove tumor, and in terms of prevention of complications?
I would rather not do a VP shunt on this patient, but use intraoperative ventricular drainage. That has the advantage of, getting immediate cerebral relaxation, and then also preservation of the CSF plane between the tumor and the brainstem. So this is our policy. But sometimes patients are referred to us after getting a VP shunt done outside. So in those cases, we do face a problem of the dissection plane being lost at the middle, especially at the middle cerebral peduncle.
Okay, thank you. Thank you.
John Lee from UPenn, Philadelphia. I just want to make a comment after I heard Dr. Ashtagiri talk about radiosurgery and surgery. So I do all the radiosurgery for acoustics, and I do the surgery. And I remember when Andy Parsa, I listened to him give a talk, the late Andy Parsa, and he said specifically, we're going to draw out where we're going to resect up to, and then we're going to plan the radio surgery. And my heart just like, I just revolted against that because even though I do the radio surgery, I just did not think that was fair to the patient. I felt that if I'm taking them to the operating room, I need to give them everything I have, whether it means I get 2 kidney stones. I got 2 kidney stones from doing these long surgeries. But whatever it takes to achieve an excellent outcome, because I will get better and I will get better. And now I will, so, and I love there was a recent paper by Leonetti's group and Anderson in Loyola, 400 cases to get for a learning curve. I thought that was fascinating. So I disagree respectfully. I think that it's not so much you should not do both the radiosurgery and the surgery. I think it's a certain personality type that needs to be selected to do these type of cases. It has to be somebody, and in Korea, we have a little saying, we say that the student has to have a heavy butt. And what they mean by that is you have to be able to sit for hours and study. And I think that's one thing that's unique to us is that we like to operate, and whatever it takes, we will do. But of course, not at the patient expense. So thank you so much.
I think on that note, Dr. Lee, thank you. I think we'll close the panel, and any other questions we can ask during the break. Thank you.
Thank you.
Thank you. I now invite the spine panel, our 2 moderators and all panelists. While they are setting up, 2 things. The dinners tonight and tomorrow, there is a seating plan. Please go choose seats if you would like to sit with your own friends or maybe sit and argue with some of the people you are arguing with. Go choose, put down your names, and if you don't, it's open seating when you get there. And make sure your name is not already written there on some of the reserved tables. The second thing is, as you know, I'm AANS president. The meeting is in Boston in April 2025. Roberto Suazo, who's here, I would love to capture as many testimonials as possible to kind of help us put together a nice promotional video to invite the whole world to Boston. As you know, all 4 continental societies are invited. So I'd love to see particularly the well-known faces on that video. When you have a minute, you have a room right there, correct? It's going to take you 1 to 2 minutes to say a few words, today or tomorrow, correct? Thank you. And now my pleasure to introduce the 2 co-moderators, my partner here at UT, John Quinn, who does complex spine deformity surgery, and Dan Ho from University of Florida, and I'll introduce everybody else here on the panel.
Well, good morning, everyone. And we're going to be taking a 180 from all these fantastic microsurgical talks. Discuss, it's a great opportunity to discuss some complex revision cases, both adult deformity and some complex tumor cases with some world-renowned faculty. As an introduction, we have Dr. Art Kleinberg. He's a faculty at UT Houston in the orthopedic side, one of the world experts in adult deformity. Adult deformity. Dr. Stark is one of my partners. She's expertise in everything, minimally invasive, I think is her specialty. Dr. Williams is also one of my co-faculty who's just started, but is a primary trauma specialist, but also becoming more interested in adult deformity as he does more surgery. And then Dr. Tatsui, who needs no introduction, he's faculty at MD Anderson with an expertise in complex spine tumors. Dr. Than is at Duke University and also an expert in everything. And Dr. Askorian, who's joining us from Swedish. And so welcome to everyone. How do we connect to this podium? Yeah, okay, here we go. So we're gonna have a case-based discussion. My initial first, just one, it's not showing on that screen. Yeah, oh, there we go. So this is a 73-year-old female who had multiple prior surgeries. Most recently, a T3 to T10 extension of a fusion at the EVO OSH. She presented with severe neck pain, chin on chest deformity, with progressive lower extremity weakness, instability, myelopathy. She said that those symptoms developed immediately after her surgery and had been progressively worsening over the past several months. She had been ambulatory prior to those surgeries, but now she's unable to ambulate without a walker. She's unable to look upright without severe pain and kind of walks with a bent backward posture, also developing shortness of breath when she stands upright. She has a history of osteoporosis. And again, the prior surgeries, which the pathology actually started with a thoracolumbar fracture, with subsequent junctional collapse, a short segment fusion, then a long segment fusion, and then a extension of the upper thoracic spine 6 months prior. On exam, has distal lower extremity weakness with myelopathic symptoms, and also has protrudent hardware at the cervicothoracic junction without any breakdown, but very tenuous skin. So these are her films. And I've written that, or showing some of the important thoracolumbar alignment parameters and cervicothoracic junctional alignment factors. This is her myelogram, which again shows a focal kyphosis at this T3 level, the area of the upper instrument vertebrae, with a translation and angular kyphotic deformity with severe central cord compression. And so we got some additional imaging studies just to identify whether there's any flexibility. And on the left is the upright, on the right is the supine CT. So it doesn't appear to be very flexible. She had been in the process of undergoing some degree of medical optimization. It's been started with a PTH analog 3 months prior, was in rehab, but she had been progressively becoming myelopathic, losing function. So we decided to proceed with surgery. So at this point, these are how I think about these complex cases, in a set of objective goals. I wanted to get the input from the panel. Dr. Kleinberg, would you give us your insights?
Thank you for this easy case. Very straightforward. I too have a heavy bottom. I don't know who said that, but I like that. I'm going to use that with my residents consistently and tell them that their butts need to get larger and sit more often. I think again, this is spinal disaster, right? We've taken a small problem and we've made it a horrific problem. And part of this is, I think there's some hubris sometimes in our spinal colleagues, perhaps ourselves as well, where we think we can tackle everything. And the problem is we make these problems a disaster. And so, there could have been real mitigation of this problem ahead of time, optimizing the bone before we think about doing this horrific fracture, which is clearly an osteoporotic patient with a compression fracture, then gets more and more surgery rather than fixing their underlying problem. So that's an issue, and obviously, John, you corrected that. Then the extension up to this fusion up to the upper thoracic spine, creating a negative T1 tilt or very flat T1 tilt, forcing this patient to develop this kyphosis above. Again, this could have been mitigated obviously this wasn't done here at the dreaded outside hospital, but we all work at the outside hospital, don't we? And so we need to be careful about how these things are corrected. Now with a continued high T1 slope, Now with significant kyphosis and neurologic dysfunction, now we need to intervene. And this is a problem. I would love to see more kyphosis in the thoracic, upper thoracic spine. That's a really difficult operation, though. It's much easier to impart lordosis than kyphosis, just because of the osteotomies that we're able to do. Sometimes if we can find a non-union in that segment, I'd like to use that non-union and I'll extend against it to try to impart some additional kyphosis, maybe decrease the rod density to match the patient's density. Again, this is sometimes, even though I'm the orthopedic surgeon, maybe one of the few in the room, sometimes stronger is not always better. And so we use more rods and more metal, but that does create a problem. Now that we've identified this patient, though, really the only answer is an osteotomy. And so we need to think about decompressing and relaxing the pressure on the spinal cord. So the good news is that the majority of the angular deformities in the thoracic spine, where we can more easily do a vertebrectomy. If this is in the mid-cervical segment, it's a lot more complicated. In the lower cervical segment, very complicated because of the risk to the eloquent nerves in the hand. And so this would be, so in my hands, we would be talking about relaxing the thoracic kyphosis and extending the fusion into the upper cervical segment, likely to C2, with a T3 vertebrectomy to restore angular alignment and to relax the spinal cord. That is not an easy operation. That is fraught with lots of disasters, including neurologic compromise on the table.
Eric, do you think it's important to go all the way up to C2 here? If you go to the can you hear me? Oh, sorry. Yeah, Eric, do you think it's important to go to all the way to C2 here? When you look at the cervical myelogram, her cervical alignment is reasonable. There's not a whole lot of degeneration there. And so I wonder what would you think with the, completely agree, great points, by the way, about relaxing the thoracic sort of lordosis there. But what are your thoughts about doing the T3 VCR, but then getting really good fixation at C7, T1, T2, and then giving her a chance at retaining cervical range of motion?
Yeah, so it's good. I love it. I love the challenge off the bat. I think I think the problem is so now we're going to rely on 6 pedicle screws above vertebral column resection in a patient that's failed how many times? T2, I had the vertebrectomy failure, then had the posterior fusion failure, then T10 pelvis failure, then T3 pelvis failure. I love doing revision surgery from somebody else, but I hate doing my own revision surgery. And so I tend to be more aggressive because I say, boy, this patient's come in now myelopathic with horrible deformity. I don't want to, do I have a fused iliac spine? I don't. I want her to live and do all the things she wants to do, but I really don't want her to have a revision after my surgery. So I tend to be more aggressive.
Great case. A couple questions. So the first is, when planning this, I'd be interested in the panel's thoughts about what you would sort of predict is the best age-adjusted alignment for this patient at this age. And the second follow-up question, once you've determined that intraoperatively, what are the modalities you use so that before you leave the OR, you think you've best matched that preoperative alignment?
I think nowadays, I think we're too focused on alignment, and I think too many people are getting fusions. I mean, this is, I don't have our pre-op films, but I think, this population is mostly osteoporotic. They're going to have poor bone density, and regardless of how good your planning is, they're going to get, I think they're at high risk for PJK and distal junctional failures. So I think this is a complicated population to do surgery on.
So I'm a tumor guy, and I do a lot of these situations after radiotherapy where I see this kyphosis and patients that were heavily radiated here. And now I might be saying something here that might be a sin, but I am sometimes not aiming towards too much of a complete correction here. So I rather think that the pathophysiology is this bolstering, this curvature, and probably the mechanical contusions that this patient is getting during the course of the days. So what I strive in my cases, at least especially because I know complication rates, especially incisions here in this upper part here, a lot of them, these patients got radiated, they're malnourished, and so I would say, I would try to do for sure an osteotomy to try to realign, but I would like to use laminectomies. I would like to do an ultrasound that will confirm that the spinal cord is decompressed. Not necessarily I need to decompress by correcting the deformity, but I can decompress by removing, resecting some of the dorsal bone there, and I can even resect more than one level if needed to. And then certainly I would like to stabilize this patient the best as possible. I will go to C2, and I'll have a low threshold to go to the occiput if we have to, but I would like to give the occiput not fused so she can have a little bit of motion and help her with quality of life.
I think you have to have a surgical plan. You got to know where you want to put this person ahead of time. I think this is not a wing it surgery, so I wouldn't. So I don't think I'm not that anyone's suggesting that, but I do think you need to have a plan. If you fail the plan, you plan to fail. And so I think you need to have some alignment goals and some idea about where you want to go. This patient's massively retroverted because of her junctional failure. She needs appropriate alignment so that she can have a neutral neutral alignment and be able to live the rest of her life. And if you don't align her well, she's going to end up with whatever fixation end you put her in, she's then going to end up with a dens fracture or a C1-2 ring fracture, and then a fusion of the occiput, and then you really are not going to get any Christmas cards from her because she's going to be very, very unhappy.
Well, you've contributed a lot to the literature on alignment, and I think for any given patient, we always have an idea of what our goals are. What would be some of your strategies for ensuring you've accomplished the appropriate alignment intraoperatively? So clearly, this patient failed because she's overcorrected, but obviously you'll look at a CT thoracic spine and see if she's fused or not. Hopefully, within several months of her last surgery, she's not, and you can get some of that relaxation back. But what are some things that you're doing intraoperatively to make sure that you're approaching your goals?
Yeah, so I think there's a couple of good tricks to look at. So there's slope numbers that we have. So the T1 slope and the L1 slope. So if you can get those slopes within 5 degrees or so, that tells you that they're well aligned. And then you want the C2 slope to sit on top of that. An easy look for it is you want the back of the skull to be aligned with the posterior aspect of the thoracic spine. And that gives you a sense about the intertranslation. And then for this patient also, they need some restoration of height. Their head is both slid forward and it's also slid down. And so you need to kind of restore both of those things to try to get for more appropriate alignment and get her in the right place. It's not easy. Intraoperative is challenging. You need to have 36-inch films, or you need to be able to get some sort of intraoperative alignment. I don't think you want to just get a C-arm shot with this and guess that you're close. I think that's really challenging. And if you can maintain and save that upper cervical motion, then you leave a little bit of a release valve so that they're able to compensate. One of the big problems here is because everything else is fused, there's no compensation. And so you got to get this closer to right than you might otherwise need to.
What are your thoughts on pre-bent rods to try to achieve some goal along it?
Whatever you need to kind of have a pre-bent rods, at least means to me that you've got a pre-op plan. And so I think if you've got a pre-op plan, that's good. And then if you have pre-bent rods, and that gives you at least closer to it. Rods are just a device just like anything else. And so they're subject to your plan and making sure that you can execute properly. And so I'm totally fine with that.
And I think I had some of the films from prior, and I think a lot of this was not only poor planning, but also intraoperative positioning is what set this up. And the second operation where they didn't account for that is what, if you had our films from before, and the fusion to the lower thoracic spine is unchanged. And when they extended, they just made a less invasive procedure. They just opened the bottom, put straight connectors and connected it straight out. And a lot of this is positioning the bolster too high, keeps their thoracic spine in relative lordosis. So some of this could have potentially been avoided with some simple steps. So PJK is very, very common just because of the patient population we're treating. Recurrent PJF is a whole other story. And it's a sign of a pretty significant, substantial malalignment problem. Here are some of her parameters. And with her, the obvious alignment issue is they extended her lordosis well into the thoracic spine. So if there's kind of more recently been a realization there's different subtypes of spinal shapes, but in all of them there's a clear inflection point in the lumbar region. Some of the apexes are lower down, others are higher. She's in the subtype where it's her inflection from lordosis to kyphosis should have been upper lumbar, and you can see there here. Her otherwise her spinopelvic parameters are pretty well aligned, but she has no thoracic kyphosis. On average, the thoracic kyphosis should be about 80% of the lordosis, which was not planned for here, and it wasn't clearly whether it was positioning or just execution. But I agree, planning is kind of the key for these, especially complex procedures. And we have different types of software that we can try to simulate and recreate. This is using SurgiMap, which is it's a very unsophisticated, but it gives you an idea. So the idea of whether the goals, I agree with all the panel, restoring the cervical thoracic alignment and treating the patient's myelopathy are primary. But if you don't restore the thoracic kyphosis, again, you could be a setup for another problem. As you see, the middle film is what would be simulated if you just done the VCR without restoring kyphosis and creating the apex, or shifting the apex lower down. So what I did was a two-stage procedure, very similar to what Dr. Kleinberg had mentioned, a two-stage procedure. The initial surgery is trickier just because of the kyphosis and angulation. The angle to get the instrumentation in is a very narrow window. So putting them in a halo during surgery, extending their head for the instrumentation, doing the posterior osteotomies across the mid-thoracic spine, pre-contouring the wad and even distracting a bit to induce some mid-thoracic kyphosis, and then translating the head back in the Mayfield. I did a second stage multi-level ACF just because her bone quality was very poor and her lateral masses were very small. So this is just the mechanism of further failure is flexion. So having the anterior plate helps resist that to some degree. So this is her 5-year follow-up, and she'd been doing very well. 1 month ago, she felt a pop, and now it's back pain.
Switch to the other podium. Thank you.
Okay, John.
By the way, I forgot to say, Dan is the current CNS president as of yesterday.
Oh, great, thank you. Thanks, Josh. Thanks to the meeting organizers. It's fantastic. Excellent program, and I'll move things along. This is a case, and I like the comment. I like doing revision surgery, but I hate doing my own. This will be an example of my own revision. So this is my disclosure. So this is real quick, 72-year-old guy, 6-month history of back pain. So prior to that, always healthy, very active, never had back issues. He described the pain as worse in the morning and would get worse, improve over the course of the day. And he had this L2 distribution, sensory deficit. Again, he was very active at baseline. He was actually an endurance runner. And so he, initially underwent conservative therapy for this back pain, but he had no improvement. So subsequently, his primary care got a lumbar MRI. These were his x-rays when he was first evaluated. So, relatively reasonable for his age group. And this is his MRI. So this is his presentation to the office. So just curious, Claudia, I'm just going to put you on the spot. This is probably like an everyday Monday morning for you. So what are your thoughts?
Yeah, so this, how old is he then?
He's 72.
72. Okay.
And no other medical history, no history of anything.
Yeah, right. Yeah, you can see that there is 432. There is a process, like infiltrative process there, causing a pathologic fracture of L2 with a moderate degree of core compression there. moderate to severe, I would say, probably involvement on bilateral foramina. And certainly we need a diagnosis here. So that I will not touch this guy without knowing what I'm dealing with. He's not like losing function, right?
Yeah.
Of course, getting complete investigation.
Yeah, and so he had these imaging studies. Okay, so, and so you say, it's obvious, but when you say get a diagnosis, how would you do that?
Yeah, so I'll get a biopsy, and in Anderson, usually I get my IR, interventional radiologist, I have them, my speed dial, I call them, and I organize. Usually I can get a biopsy done in 2 to 3 days, and I can get a diagnosis within a week time frame.
Anybody surgery before, everyone open biopsy or surgery prior to getting a tissue diagnosis?
I might suggest a pan scan, CT chest having pelvis to see other areas of disease prior to jumping into this.
Make sure it doesn't have like a lung lesion or a colon lesion.
Yeah, at this age, you always think about multiple myeloma or other primary tumors if there is no other site of disease, right?
Sure, absolutely, because as you're pointing out, the management is entirely dictated by the tissue pathology, right? So he actually had a CT guided biopsy when he came to see me, and the path was chordoma. So management. So he's more or less neurologically intact. He has a L2 sensory deficit. Again, he's still very active. So diagnosed chordoma. So.
Yeah. So I would say, can you go back to the MRI again? Yeah. So this is an isolated disease, right? So in theory, you could cure this patient.
And the rest of his scan was negative. He had no other signs of disease.
Yeah. So I would say in our philosophy is that we would strive to try to do an en-bloc resection here, right? So it's kind of he seems to be relatively in good health. He could tolerate a major procedure. Usually we do this in 2 stages, an all-planned operation, explaining the patient. So this is L2. It's possible that we'll be able to preserve those nerves, but I will prepare the patient for a possibility of that. We have to maybe sacrifice one of them in order to get this full resection there. It's a little tricky because both pedicles seem to be involved. So it's not an easy block because you have to cut to stop there and you have to dissect. But there is one thing that I learned in my practice is that the tumor never is free on epidural space. It's always contained by the PLL. And I learned this with my partner, Larry Wines. You can do the facetectomy. You have a marginal margin, but you can separate there if you go slowly. And you can sometimes, quite often, not violate the tumor and create like a little space there where you can work on the second.
Yeah, great point. So I just had to catch, obviously there's anterior disease, right? And it does start to go in the pedicle. Is there a point at which you say this en bloc is not really technically possible because of the extent of the posterior elements?
I would say if this was creeping more around you have to have at least the lamina and one pedicle free so you could open the ring and get it there, right? So this would be in the borderline of not being unblockable. I would say in the best hands, there is a chance that these would be violated. But still, I would say that if you do, even if you violate and you could do a planned violation there, which is not a capital sin in my opinion, but you could resect this tumor, create this patient disease-free macroscopically. I think he's going to have a better outcome than if you just do what Mark Bielski, for instance, proposed, which is separation surgery and then radiation there.
Okay, great.
The one trick to this too is when you do the 2 stages. So he's going to go to the back first, instrument, decompress, remove the elements, and then go to the front for the delivery of the tumor. But when you're in the MAC, don't miss out on the opportunity to trace out the nerve roots and then to do the lateral body dissection first. Because the difficult part in the front is getting to the far side because it's not a true anterior approach, you're actually on a lateral approach. And so the far side is really challenging. And that if you're going to sacrifice the root, that's the route you need to. However, an L2 sacrifice route is a big problem, not a little problem. That's a potentially not walkable problem or walk with significant crutches or ambulatory devices. So that's a challenging discussion with the patient. And then you also want to make sure that you can do all the adjuvant therapy, including proton beam for this, which is probably what it will need.
How many levels would you instrument for fixation?
I would go 2 above to below with a fibula graft, vascularized fibula graft in there. And I would consider putting a quad rod. And now I'm having more experience with the carbon fiber instrumentation. I would try to use, especially because we're going to consider proton therapy. And I would not put a metallic cage there. I would put a carbon fiber or a PEEK cage in the front or as well to reconstruct that.
Oh, perfect, because this is going to be a good example of why you're right. Okay, so what did I do? So I did a pre-op embo just to take some of the, I actually planned this as a single stage posterior only approach. My plan was, on the scans, it does go through the pedicles into the posterior elements. So I was going to, not truly an en bloc, but use, osteotomes to try and minimize the spillage of tumor cells in the field. I did, again, pre-op angio. We have a great, fantastic team of endovascular surgeons at our institution. So I did all that, just as you said, PLL perfectly contained all of the tumor coming from the vertebral body. And so I'm doing my reconstruction. I should say this. So there are a number of mistakes here that I made. So the first was, I got, the path to hell is paved with good intentions, right? So this is a very active guy. He's a distance runner. And I thought, how can we, try and minimize, how can we try and preserve motion segments, for this guy? And I thought, well, we get really good fixation, get great bone quality, get rigid fixation, try and minimize the length of constitution. So this is the intraoperative X-ray. So there's a number of unfortunate issues here. So because of positioning, John made a good point. He, with the complete resection, so I got an en-bloc, more or less en-bloc resection. He just kept falling through the Jackson table. I could not. I mean, this is one of multiple. I practically irradiated him on the table of trying to get this cage to sit right, and I could not get it to sit right. It kept tilting and tilting because he was, he was basically falling through the open part of the Jackson table. And so this was one of many shots, but that's what I did. This was his initial post-op X-ray, and for the moment, I lulled myself into thinking, okay, we did the oncologic operation, we reconstructed his spinal column. He's going to be so glad that I preserved motion segments, and I thought the X-ray looked like actually at least better than what we had intraoperative fluoro. So he comes back and sees me at a regular 6 to 8 week post-op check. He's doing well, he's nuanced intact, but he says, hey, I'm hunched forward, and I feel like something's sticking out of my back. So I'll just go ahead and see, this is what his X-ray looks like, right? Okay. So he says to me, he says, do I really need to do anything about this? So I said, yeah. So we get the CT scan. He actually, because it's relatively early, he, relatively speaking, corrects. You know what I mean? This is just a supine CT. So he's still quite mobile and he corrects a little bit. So I'll ask anybody now, I'm fixing this, right? So, like you said, I hate to do revision surgery on my own, but you have to do the right thing. So what would you do?
Go bigger.
Oh, yeah.
I would say the cage is not as bad there. If you go big, like 3 above, go another 3 above, 3 below, I would put screws with cement. I think that, the screws, when you don't achieve a fusion, I think the cement helps, getting more durable construct and a stronger construct. I'll go with quad rods. And I think by putting him on the table, once you get your screws out and you put the screws above, he's totally disconnected. So you can probably align him just
right. Yeah, a lot more better biomechanical advantage. You have multiple points of fixation.
I think this is, I think technically the surgery was done great. I think this is the problem with some of these cages is that, you put in that cage, it goes with pistons right through the end plate. And so I like going lateral and putting those long end plates. I think it provides a little bit more support and it's not going through the hypophyseal ring. So I think that's probably what happened.
Yeah.
The other thing too is, so because you're nervous about your table positioning, you have a plan this time around to make the table work better for you?
Yeah. So I know we're running maybe a little bit on time. So I went 3 levels above it and then add an additional level. His bone quality actually was really good. I mean, this guy was an endurance runner, even despite his age. So his bone quality was good. And this was our closure. And he's now almost 2 years post-op. And so here's his x-rays. I think he is fused actually through the cage. All the graft is still there. Unfortunately, I didn't take your advice about the implant. So he has titanium cage and implants, but he did get proton beam adjuvant treatment. So he's disease-free so far, approaching 2 years. Lessons learned for me, certainly in this case, I was very much focused on the oncological part, which I think he had a good result, but some technical details with regards to the actual reconstruction that came back to bite me. So I'll just say this again, Jacques said it, I'm incredibly honored. We have this great relationship between our organizations. Jacques is a superstar internationally, but we claim him as our own here in the US. He's our superstar. And so as he mentioned, he is the president of the AANS. And then, as he mentioned, we have our own meeting with the Congress of Neurological Surgeons. So if you, for those of you who are domestic, I please invite you to join us. For those international, I hope you will be able to join us as well, either in Boston or Los Angeles next year.